Welcome to Viewpoints. My name's Ross Elliott. Joining me today is Tom Russo. Tom is the Director of Emergency Preparedness for the South Carolina Department of Health and Environmental Control in Conway, South Carolina. Tom's just completing his master's degree and has written a thesis on strategic policy for pandemic vaccine distribution. Tom, if you could tell me, what does vaccine distribution have to do with Homeland Security?
You know, in a public health emergency, one of our objectives is to protect not only our critical infrastructure sectors, but as well the general population. So if we have vaccine, but we're not able to get it out quickly and broadly, then we kind of compromise our ability to protect those sectors, critical workers, as well as the general population.
Tom, from a broader perspective, how does public health and that discipline contribute towards Homeland Security?
Public health has contributed toward Homeland Security by helping to coordinate hospital emergency response, mass casualty, mass fatality, and really step in where ESF 8 in the Emergency Operations Center in the NIM structure really kind of asked public health to step up and kind of coordinate those different medical assets and responses.
Okay. Tom, if we could drill down a little bit, tell us a little bit about your thesis. What was it you were trying to solve?
It's interesting you should ask that because it really grew out of when H1N1 had been announced as a public health emergency by Secretary Sebelius back in April '09. And we were beginning to look at topics for thesis. And I realized that with the information that was coming down from state and federal public health authorities, that we had some real issues with the way we're going to get vaccine out to the general public, as well as our critical infrastructure partners. And that's when I realized the model we were using was departing from all the planning that we had been doing for 6-7 years. And that was the genesis of that whole thesis, which was how do we get vaccine out quickly and broadly to the general public as well as critical infrastructure partners. Those partners being emergency management, first responders, law enforcement, hospital personnel, doctors, all those individuals that are going to be protecting the general public in a public health emergency.
Tom, I remember on a couple of the projects during the sessions that some of the data on vaccine distribution was very difficult to come by. How did you overcome that?
Well, there is some literature out there, but a lot of it was going back into the General Accounting Office reports that looked at those same kind of issues. And that helped me kind of frame some of the questions as well as some of the issues. The H1N1 event itself provided a good source of information because I did interviews of representatives from some of our critical infrastructure partners. HHS, McKesson, who was key in vaccine distribution, state and local authorities, local doctors. And so their experiences was kind of one data set, and then being able to compare and contrast that to what the literature suggested really gave me some opportunities to contrast information about what is out there on distribution. And the bottom line was our current plans are not executable because they're based on a manpower source for public health that's no longer like it was 50, 60 years ago.
Also, if it's based on manpower and we're having a pandemic or an epidemic of some kind, it sounds like that could be a real weakness.
And that's what I found both in the literature as well as from the interviews, is that public health no longer has the manpower it had in the 50s and the 60s when we were doing these mass vaccination campaigns. We've had budget cuts this past decade, and that just compounded a declining public health infrastructure. So for example, in our own state, we went from 1,200 public health nurses down to 400 nurses. In our own region, we went from 120 nurses down to 40. You cannot do mass vaccination campaigns with 1/3, 2/3 the workforce that you had 10 years ago. So the thesis looked at how do we develop the manpower resources to be able to do mass vaccination quickly and efficiently to meet the HHS goal of vaccinating 300 million Americans in 6 months.
So what did you find? Where did this research lead you?
It led me to really look at alternative health, allied health occupations, such as pharmacists, dentists, and a host of others that could help out with vaccination services, including EMTs and paramedics. I mean, and I know state to state that's very different. Pharmacists, pharmacists over the last 16 years have been working to develop their professionals to be able to vaccinate. They now are in a position to be vaccinators, but public health was not aware. They may have been aware, but not really ready to bring them on board as vaccinators. So the logistics of doing that were cumbersome because we had not worked out the licensure issues, the credential issues, and the legal issues. And kind of what I found in the research was we have to look at the scope of practice for any profession that we want to include as a vaccinator. Take, for example, dentists. Dentists would be more than willing to help in a public health emergency, but their scope of practice is limited to the neck up. They can't vaccinate in an arm or a leg unless their scope of practice is broadened. So what are the licensure issues, the credential issues, the legal issues, the regulatory issues? So we've got to bring together legislatures who make the laws, professional associations that credentialize those professionals, and then the professionals themselves, and bring them together in collaborations where they can work out these issues in advance of a public health emergency. What we found this past time is we were working these issues out in the middle of the emergency, and that's what we need to get away from.
Sure. Do you think that you'll be able to advance this in South Carolina?
I hope so. I would like to see some special projects, pilot projects hosted by HHS, and in the thesis I talk about that, how we can do some of those things. But I think the special projects would be where we can take states that have a centralized system, because that's, I think, more helpful than a decentralized public health system, and begin to look at working out those issues. We've actually done that before with the Emergency Health Powers Act. That was a kind of a federal to state, and where the states looked at all their public health laws and updated those to 21st century. A lot of those had dated, way back in the 50s and 60s. That's the scope of the project, but that's what I believe and what I found needs to be done to really increase the capacity for vaccinators for a public health emergency.
Sounds like a real interesting contribution, Tom. In terms of the nation's homeland security, how does your research contribute towards making Conway or Myrtle Beach a safer place?
One of the recommendations that came out of the study, in addition to the manpower and the credentialing issues, was to establish a pandemic vaccine distribution policy. We have policy for what I would call actual vaccination. In other words, and that is the CDC allocation guidelines in a pandemic. How do we get vaccine into arms? Who's eligible by age, by risk, all those things. We've done that. We've got that down really well. I mean, who gets vaccine? Over the last 10 years, HHS has established a policy of vaccine production self-sufficiency. During H1N1, 63% of our vaccine was imported from other countries. So currently, the U.S. only has one vaccine manufacturer. 4 of those that we got the vaccine from are from offshore. Part of the biosecurity pandemic preparedness legislation of the last 5 years was to invest in expanding capacity in the U.S. so we become more self-sufficient to produce influenza vaccine. Those are coming online probably by 2012, 2013. We'll increase our onshore capacity for vaccine production. So and I talk about this at the end of the thesis, is to look at this as a triangular network of interdependencies between production, vaccination, and distribution. So the distribution I found was a piece that is lacking. That's the piece we need to build up. We have the vaccination piece, and we have the production piece. What's missing is distribution. And that's the piece I think we need to really work on.
Tom, thank you so much for spending time with us today.
Well, thank you for asking.
And thank you for your contribution to Homeland Security.